Unfortunately, one of the things that has become so common these days is breast cancer. We see a lot of patients nowadays who have recently been diagnosed with breast cancer, and not only have they been diagnosed with breast cancer, but commonly nowadays we see patients who have been tested positive for the BRCA1 gene or the BRCA gene, which indicates that they have a propensity to developing cancer in their opposite breast. Many times those patients have elected to undergo bilateral mastectomies as opposed to being in a lifelong fashion concerned about the opposite breast. For this reason, we've become very accustomed to doing breast reconstruction in patients having bilateral procedures or unilateral procedures. One of the most common types of reconstruction options available today is a so-called three-stage reconstruction. What that means is that at the time of the mastectomy, the initial procedure is done to begin reconstructing the patient's breasts. Oftentimes what that means is the placement of what's called a tissue expander. A tissue expander is essentially an implant with a port built into it through which volume can be added after the surgery. By doing that, we put in this device which we take and access through a small port using a needle, and we add fluid to gradually stretch the muscle and the skin overlying this area. At some point after that, once the patient and I are happy with the size of the breast, the patient's taken back to surgery as an outpatient, and that tissue expander is exchanged for a permanent implant. Now that permanent implant might be full of saline or silicone gel. The third stage in this reconstructive pathway is a nipple reconstruction. Many times the general surgeons need to take the nipple because there's breast tissue which is located in the nipple itself. When the nipple is taken, many patients feel like they don't have a complete reconstruction without having that nipple reconstructed. So as a third stage, done sometime after that second procedure, the nipple is reconstructed again as an outpatient, and those patients then feel like they finally have their breast back. The options available to patients that are having breast reconstructions are numerous, and in some ways it's better to see a physician and talk about the various options available to them rather than saying any one particular option is better for all patients. Sometimes those patients elect even to have delayed reconstruction, and that would be a reconstruction done after the time of their mastectomy, and sometimes we even recommend that they have a delayed reconstruction if in fact the patient's going to undergo radiation or some of the more aggressive forms of chemotherapy that sometimes patients undergo.